Lecture 3 transcript, active phase arrest and the 6-centimeter gait. Transcript. This third lecture is about arrest of dilatation, but the deeper subject is proof. The cervix is not changing. That is an observation. Active phase arrest is a diagnosis. Between those two sentences lies nearly the whole discipline of modern labor management. A patient may have no cervical change because she is still before active labor. She may have no change because the uterus is not generating enough force. She may have no change because the head is malpositioned and the force is poorly applied. She may have no change because membranes are intact and the mechanics are incomplete. She may have no change because the fetus or mother no longer permits the time needed to test the process. Or she may have no change because true active phase arrest has occurred. Those are not synonyms. The danger in the delivery room is that the first sentence, the cervix is not changing, begins to carry the emotional force of the second sentence, labor is arrested, before the criteria have been earned. That is how an observation becomes an indication for cesarean without enough physiology, enough evidence, or enough humility. So the whole lecture can be organized around one question. What must be true before absence of cervical change deserves the name active phase arrest? The first answer is phase. Active phase arrest cannot be diagnosed before active labor. That sounds obvious, but historically, it was one of the most important places where obstetrics became overconfident. The older Friedman-era framework placed the active phase around 3 to 4 centimeters and expected faster dilation than contemporary data support. That older curve was not foolish. It was a real attempt to make labor measurable. But as we said in Lecture 1, a labor curve is not anatomy. It is a statistical description of a population under particular practices. The modern correction comes from the Consortium on Safe Labor and the way ACOG and GABI interpret those data. From 4 to 6 centimeters, labor can still be slow and variable. Nulliparous and multiparous patients may dilate at similar rates before 6 centimeters. The inflection into more reliable active labor appears around 6 centimeters. And even there, we should remember that a threshold is a clinical boundary drawn across biologic variation, not a magic transformation in the cervix. Still, the boundary matters enormously. ACOG recommends that 6 centimeters be considered the start of active labor for management purposes. It also states that active phase management and active phase arrest standards should not be applied until at least 6 centimeters. GABI says the same thing in direct clinical language. Neither a protracted active phase nor arrest of dilation should be diagnosed in a nullipara before 6 centimeters. This is the 6-centimeter gait. The gait is protective because the cervix before 6 centimeters is often still in a mixed state. It may be dilating, softening, effacing, aligning, and responding unevenly. The patient may have painful contractions. The team may have been working for hours. But if the cervix is 5 centimeters, the absence of rapid dilation does not yet have the same meaning as it does at 7 centimeters. The physiology has not fully entered the phase where active phase expectations are fair. That is why a 5-centimeter patient should make you careful with language. You may say prolonged latent labor. You may say prolonged latent induction. You may say slow progress before active labor. You may say the patient needs reassessment. Amniotomy if appropriate, oxytocin if appropriate, rest, analgesia, position evaluation, or a discussion about the indication for delivery. But you should not say active phase arrest. The phase has not opened that diagnostic door. The second answer is rupture. The modern active phase arrest definition requires ruptured membranes. This is not an arbitrary ritual. Rupture changes the mechanics of the first stage. With intact membranes, the amniotic sac can buffer force and change how the presenting part applies pressure to the cervix. Once membranes are ruptured, the fetal head can press more directly against the cervix and lower uterine segment. That pressure can make contractions more effective, and it also makes the contraction trial more interpretable. Rupture also allows the use of an intrauterine pressure catheter when contraction adequacy is uncertain. That matters because arrest is not only a statement about the cervix, it is a statement about the cervix after the uterus has had a fair chance to work. So before diagnosing active phase arrest, ask, are membranes ruptured? And if not, why not? Sometimes rupture is not safe or feasible. There may be a high-presenting part, concern for cord prolapse, uncertain presentation, or another reason not to rupture. That changes management, but it also changes the confidence with which we can use the standard definition. A diagnosis built on incomplete mechanics must be spoken with that limitation in mind. The third answer is contraction adequacy. Here, the beauty of the physiology becomes practical. Labor is not dilation alone. Labor is force applied to tissue through a fetal presenting part and a maternal pelvis. If the cervix is not changing, one of the first mechanistic questions is whether the powers are adequate. External tokodynamometry can tell you when contractions occur and how far apart they are. It can tell you frequency and timing. It cannot reliably tell you strength. The external monitor records a relative signal produced by change in uterine shape against the abdominal wall. Maternal body habitus, belt position, movement, and signal quality can all make the tracing look more or less impressive than the actual force generated inside the uterus. That is why IUPC matters. After amniotomy, an IUPC can measure intrauterine pressure directly. It can show contraction intensity, resting tone, and total uterine activity. It can help distinguish a uterus that is contracting often but weakly from a uterus that is generating adequate force without cervical response. It can help titrate oxytocin when the external monitor is unreliable. It is not needed for every labor, and it should not be worshipped as a device. But when the diagnosis depends on whether the uterus is doing enough work, it can convert an impression into a measurement. The traditional measurement is the Montevideo unit, or MVU. MVU is calculated by summing the amplitude of contractions above baseline over 10 minutes. Historically, more than 200 MVU has been treated as adequate uterine activity. ACOG preserves that threshold in the active phase arrest framework, but it also reminds us to be honest about the evidence. The 200 MVU benchmark comes primarily from an observational study of 109 patients in 1986, in which most patients who delivered vaginally after oxytocin induction or augmentation achieved more than 200 MVU. That means 200 MVU is useful, but it is not sacred. It is a clinical approximation. It helps answer whether the powers are likely adequate, but it does not replace the rest of the bedside assessment: fetal position, station, descent, pelvis, maternal status, fetal status, and whether progress of any kind is occurring. GAB gives a more physiologic picture of adequate contractions. In a normally progressing labor, after inadequate uterine activity has been identified, oxytocin is usually increased until contractions occur every 2 to 3 minutes, last about 60 to 90 seconds, reach peak intrauterine pressures around 50 to 60 millimeters of mercury, and have a resting tone around 10 to 15 millimeters of mercury. In MVU language, that often corresponds to roughly 150 to 350 MVU. This is more satisfying than a single number because it lets you see the uterus as an organ doing mechanical work. Frequency matters because force must recur often enough. Duration matters because force must last long enough. Intensity matters because the cervix must actually be stressed. Resting tone matters because the fetus and uterus need recovery between contractions. A labor pattern can fail because one of these elements is wrong, not merely because the contraction count looks unimpressive. Now, the fourth answer is time. ACOG's active phase arrest definition is no progression in cervical dilation in a patient at least 6 centimeters dilated with ruptured membranes despite 4 hours of adequate uterine activity, or 6 hours of inadequate uterine activity with oxytocin augmentation. Say that slowly because every part does work. At least 6 centimeters, the patient has crossed the active phase gate. Ruptured membranes? The mechanics are sufficiently tested, and IUPC is possible if needed. No cervical progression. this is not merely slow progress. 4 hours if contractions are adequate, because the uterus has had enough measured force over enough time. 6 hours if contractions are inadequate with oxytocin, because weak powers deserve correction before they are judged as failure. This rule is not leniency for its own sake. It is a safeguard against the first cesarean. The evidence behind longer augmentation is clinically important. ACOG summarizes studies showing that extending oxytocin augmentation changed outcomes. In one study of more than 500 patients, extending the minimum period of oxytocin augmentation for active phase arrest from 2 hours to at least 4 hours allowed many patients who had not progressed at 2 hours to deliver vaginally without adverse neonatal effect. Among patients who had not progressed despite 2 hours of oxytocin, vaginal delivery still occurred in 91% of multiparous and 74% of nulliparous. Even after no progress at 4 hours, if oxytocin was continued at clinician judgment, subsequent vaginal delivery occurred in 88% of multiparous and 56% of nulliparous. Those numbers are not trivia. They are the reason the old 2-hour reflex is dangerous. At 2 hours, many patients who look arrested are not truly finished. The cervix may still respond if the contraction pattern is improved and maternal fetal status remains reassuring. A premature diagnosis at that moment converts potential vaginal births into cesareans. ACOG also emphasizes that slow but progressive active phase labor should not be a cesarean indication when mother and fetus are reassuring. In one prospective study of dysfunctional labor, adding 4 hours of oxytocin led to vaginal delivery in about half of nulliparous patients and more than 40% of multiparous patients. If augmentation had been limited to 4 hours in nulliparous, the cesarean rate would have been almost twice as high as with a longer augmentation period. This is why protraction and arrest must stay separate. Protraction means slower progress than expected. Arrest means cessation of progress despite an adequate attempt at correction. A protracted labor may be frustrating, tiring, and associated with higher risks, but if the cervix is still changing, the diagnosis is not arrest. ACOG suggests that less than 1 centimeter in 2 hours may be a conservative way to think about active phase protraction, but even that has to be interpreted through parity, admission dilation, fetal position, maternal characteristics, and whether the patient is progressing. The clinical sentence must be exact. There is a difference between she is progressing slowly in active labor and she meets criteria for active phase arrest. The first sentence calls for reassessment and management. The second sentence may justify cesarean if correction has failed and continued labor is no longer the better path. Now we need to ask what else can masquerade as arrest. The classic categories are powers, passenger, and passage, but the words can become too simple if they are not reopened. The powers are not just contraction frequency. They include contraction strength, duration, coordination, resting tone, and response to oxytocin. A patient can contract every 2 minutes and still generate low amplitude, poorly effective contractions. Another patient can have adequate measured contractions, but poor progress because the force is being applied to a poorly positioned head. The passenger is not merely fetal weight. It includes presentation, position, attitude, flexion, station, asynclitism, and fetal reserve. A deflexed head presents a larger diameter. An occiput posterior head may not apply force as efficiently and may need time for rotation. A brow or face presentation changes the mechanics altogether. A head that remains high despite adequate contractions raises a different concern from a head that is descending and rotating slowly. The passage is not merely a word for pelvis. It includes the inlet, mid-pelvis, outlet, soft tissues, pelvic floor, and clinical judgment about whether the presenting part can negotiate that anatomy. Gabby's discussion of protraction makes this very concrete. Inadequate uterine activity is the most common cause of protraction disorders, but abnormal position is also common. Occiput posterior position can prolong labor by about 1 hour in multiparous and 2 hours in nulliparous. In one series, OP position was seen in 35% of patients in early active labor, suggesting that it may contribute to prolongation in many labors. Persistent OP at delivery is much less common because many fetuses rotate spontaneously. But when OP persists, it is associated with longer first and second stages and lower vaginal delivery rates. This is why position must be examined, not assumed. A slow active phase with a well-flexed occiput anterior head at improving station is not the same as a slow active phase with a deflexed OP head, molding, caput, and no descent. The cervix may show the same number in both patients. The mechanism is different. Now consider CPD. CPD, cephalopelvic disproportion, is an attractive diagnosis because it feels decisive. The baby does not fit. The phrase gives shape to frustration. But Gabby is careful. CPD is a diagnosis of exclusion, and malposition is often the culprit rather than true disproportion. There is no reliable way to predict true CPD in advance, and decision analyses suggest that enormous numbers of unnecessary C-sections would be needed in low-risk pregnancies to prevent one true case by prophylactic surgery. That does not mean CPD is unreal. It means it must be earned.
Before saying CPD, evaluate the powers. Are contractions adequate, and how do we know? Evaluate the passenger. What is the position? Is the head flexed? Is there asynclitism? Is the station changing? What is the estimated fetal weight, and how uncertain is that estimate? Evaluate the passage. Does clinical pelvimetry suggest a problem? Evaluate fetal status. Is there time to correct or observe, or is the fetus declaring intolerance? Evaluate maternal status. Is continued labor reasonable? Only after that process does CPD become a defensible conclusion rather than a label for impatience. Now we must reconcile the local Pitocin protocol. The local protocol uses older operational language. It defines arrest of dilatation as painful contractions without progress in cervical dilatation for 2 hours after completion of the latent phase. It lists Pitocin augmentation during the first stage of active labor when there is arrest of dilatation for 1 hour. These statements do not match the modern ACOG and GABA diagnostic threshold for active phase arrest, which requires at least 6 centimeters, ruptured membranes, and either 4 hours of adequate contractions or 6 hours of inadequate contractions with oxytocin. The way to teach this is not to pretend the difference does not exist.
The local protocol is an operational document. It tells the team who orders oxytocin, who administers it, how it is monitored, when to reduce or stop it, what dose schedules apply, and when senior review is required. It can trigger evaluation and augmentation earlier than the modern diagnostic threshold for cesarean. That is acceptable if we keep the concepts separate. An operational trigger is not the same as a final diagnosis. If the local protocol prompts augmentation after 1 hour of active stage non-progress, that can mean reassess, optimize contractions, make sure the tracing is safe, consider whether membranes are ruptured, examine position, and supervise Pitocin correctly. It should not automatically mean that active phase arrest has been proven for cesarean purposes. This distinction protects both safety and evidence. The local Pitocin protocol also teaches mechanism in a practical way. It says response to oxytocin is individual and depends on baseline uterine activity, uterine sensitivity to oxytocin receptors, gestational age, cervical condition, clearance rate, and BMI. That is a compact physiologic summary. Oxytocin is not a simple dose equals dilation equation. The same infusion rate can have different effects in different bodies and at different stages of labor.
The protocol then imposes safety architecture. Pitocin requires a physician order and midwife execution. Both physician and midwife are responsible for uterine and fetal monitoring. The infusion must run through a pump. Continuous fetal monitoring is mandatory. A midwife must be present after initiation and after dose increases. Dose schedules are lower in grand multiparous and after previous cesarean. Hyperstimulation requires dose reduction or discontinuation and physician notification. Prolonged or recurrent fetal heart rate decelerations require stopping oxytocin, notifying the physician, and initiating intrauterine resuscitation. Suspected uterine rupture requires immediate cessation. These rules are not a separate topic from active phase arrest. They define what a safe augmentation trial looks like. You cannot call a patient arrested after an inadequate or unsafe trial and pretend the diagnostic criteria were met. If oxytocin was repeatedly stopped because of tachysystole and decelerations, that may be the correct safety response, but it changes the meaning of the 6-hour inadequate contraction pathway. If fetal status is deteriorating, the issue may no longer be whether the clock has run. It may be whether continued labor is safe. If contractions were never interpretable externally and no IUPC was used when appropriate, the adequacy question may remain unresolved. Now integrate this into a bedside sequence.
A nulliparous patient is 5 centimeters, membranes ruptured, on oxytocin, contracting every 2 to 3 minutes and unchanged for 3 hours. She is exhausted. The tracing is reassuring. She is not in active phase arrest by modern criteria because she has not reached 6 centimeters. She may be in prolonged latent labor or prolonged latent induction. She needs reassessment, but the phrase active phase arrest should not be used. Now she becomes 6 centimeters. Membranes are ruptured, oxytocin is running. The external monitor looks frequent, but the tracing of contractions is poor because of maternal habitus. After several hours, the cervix remains 6 centimeters. This is where the powers question becomes central. If contraction adequacy is uncertain and membranes are ruptured, IUPC may help. If uterine activity is inadequate, the diagnosis is not yet true arrest. It is inadequate powers requiring safe augmentation if mother and fetus permit. If oxytocin is used, the 6-hour inadequate contraction pathway exists because weak powers deserve time to be corrected. Now, imagine the IUPC shows more than 200 MVU consistently, or another clearly adequate pattern, and the cervix remains unchanged for 4 hours at 6 centimeters or more. The membranes are ruptured, fetal and maternal conditions have been reassessed, position, station, and estimated fetal weight have been considered. Now the phrase active phase arrest has weight.
It does not automatically erase judgment. You still consider the whole patient: fetal status, maternal status, infection risk, hemorrhage risk, progress in station or rotation, and the feasibility of continued labor. But the diagnostic criteria have been met in a way they had not been met earlier. Another patient is 7 centimeters, ruptured, with adequate contractions by IUPC. She remains 7 centimeters after 3 hours, but the fetal head has rotated from OP toward transverse. Station has improved slightly, caput is not worsening, and the tracing remains reassuring. This is where the clinician must resist a narrow reading of the cervix. ACOG's definition is about no progression in cervical dilation, but good bedside assessment still notices mechanics. If rotation and descent are occurring, the labor may be declaring that the passenger is negotiating the pelvis slowly. It may still become a rest if dilation remains absent through the required time and risks accumulate, but the decision should be made after seeing the whole labor, not only the dilation number. Now, a different patient is 7 centimeters, ruptured, with adequate contractions for 4 hours. The head remains high, OP, and deflexed, with increasing caput and molding. The tracing is category 2, with recurrent late decelerations despite correction. Maternal temperature is rising.
This patient is no longer merely a criteria exercise. She may meet active phase arrest criteria, but the urgency also comes from fetal tolerance, infection risk, and mechanical concern. In that context, cesarean is not simply because 4 hours passed. It is because the biology, mechanics, and safety signals have converged. That is the kind of reasoning a resident should learn to say out loud. Do not present cesarean as a reaction to a clock.
presented as the conclusion of a structured diagnosis. Active labor has been reached, membranes are ruptured, uterine activity has been adequate or adequately augmented for the required interval, there was no cervical progress, the passenger and passage have been reassessed, fetal and maternal status have been considered, and continued labor no longer offers a better risk-benefit balance. Now hold the key thresholds, but hold them with their meanings. 6 centimeters is the gate. Before 6 centimeters, active phase arrest standards should not be applied. Ruptured membranes make the mechanical trial and contraction measurement more interpretable. 4 hours applies when contractions are adequate. 6 hours applies when contractions are inadequate and oxytocin is being used to correct the powers. 200 MVU is the historical benchmark for adequacy, useful but not sacred. IUPC is a tool for uncertainty about contraction strength, especially after rupture when the external monitor cannot answer the powers question. CPD is a diagnosis of exclusion, not a synonym for slow labor.
And local Pitocin triggers are workflow prompts, not replacements for the modern diagnostic criteria. The final formulation is this: active phase arrest is not the cervix has not changed. It is no cervical dilation after the patient has crossed the 6 centimeter gate, after membranes are ruptured, after uterine activity has been shown adequate for 4 hours or inadequate but augmented for 6 hours, and after the clinician has reconsidered powers, passenger, passage, fetal status, and maternal status. That is the aesthetic of good obstetrics. It takes a simple measurement, the centimeter, and refuses to let it become simplistic. It insists that dilation be interpreted through physiology, mechanics, evidence, and safety. When you diagnose active phase arrest that way, the diagnosis is no longer a reaction to frustration. It is a disciplined conclusion.